Hi, I'd like to thank Claudia and David for the kind invitation to be here with you today. I'm Rajwanth Veluswamy. I'm a thoracic medical oncologist at Mount Sinai in New York. So appropriately so, we'll be discussing now the neoadjuvant and adjuvant chemoimmunotherapy strategies for early stage lung cancer. These are my disclosures. Okay. So, it's been discussed many times over, early stage resectable lung cancer is our best chance for meaningful long-term survival and cure. And so, however, as we've known for quite some time, that despite, complete surgical resection, there's unfortunately high rates of recurrence. This was even highlighted in Dr. Al-Turki's recent trial with 5-year outcomes showing the 5-year disease-free survival was only in the 60%, and the overall survival still only being 80%. The reason for this recurrence, was thought potentially because of occult micrometastatic disease, and then even possibly tumor seeding during surgery. And importantly, the majority of recurrences is distant, highlighting the need for systemic treatment strategies to try to improve these outcomes. So as previously discussed, chemotherapy is really all we've had for decades, and it only had provided very marginal improvement in outcomes. This was studied throughout the 2000s and summarized in the LACE meta-analysis, where pooled data 4,500 patients from RCTs demonstrated only a 5.4% absolute reduction of death at 5 years. So that's, you need to treat, more than 20 patients to change the outcome for one patient. That said, stage 2 and 3 disease where lymph nodes were involved had the most benefit. Stage 1A, the smallest tumors, it showed actually had a detrimental effect. The 1B tumors on size, so lymph node negative greater than 4 centimeters, was a bit kind of mixed. But there was one of the randomized controlled trials, the CLGB study, randomized according to that 4 centimeter cutoff and showed potentially some benefit. And that's where we really start having the discussion with our patients about an induction neoadjuvant or adjuvant treatment. So I think this anatomical, staging still matters in how we design our present studies with more novel treatments, because the recurrence risks are generally the same. So this question of neoadjuvant versus adjuvant for chemotherapy, at least, was studied earlier as well. A couple of trials, randomized trials. Here you can see the NATCH trial, which essentially showed no difference in survival between neoadjuvant and adjuvant approaches. But what they did find is that the neoadjuvant patients were more likely to get the chemotherapy that was prescribed. 90% completed chemotherapy in the neoadjuvant setting versus some 60% due to likely, recovery from surgery and so on. So, that said, neoadjuvant approaches offer some advantages and disadvantages that are still important today. The advantages are, as we talked about, the improved treatment delivery and better compliance, the potentially a prevention of early micrometastatic disease, tumor downstaging, and then in vivo assessment of treatment sensitivity. And we'll briefly discuss how this is actually more important today. Disadvantages, which we talk to the surgeons about quite frequently whenever we are preparing a multidisciplinary approach to management. So treatment-related toxicities, there's always a concern that they can delay surgery, make the surgery more complicated, and then additionally, disease progression through that treatment. But one would argue that if they're going to progress within that time before that, potentially they weren't great surgical candidates in the first place. And then finally, patient anxiety, which is really an important factor. Okay, so these are the current kind of approaches that we're thinking about as far as neoadjuvant or adjuvant treatments. And as you see, immunotherapy is now part of all of them. So we have 3 FDA-approved regimens with Checkmate 816. That is with nivolumab plus chemotherapy as a neoadjuvant treatment. They get 3 cycles and they're done and go to surgery. Then there are the other 2 that are approved are in the adjuvant setting. Here with the Empower 010 and Keynote 091, which essentially patients get surgery plus minus chemotherapy, depending on the trial, and then get a year or so of immunotherapy afterwards. And now we're getting data that's coming in for the perioperative approaches, which is around 4 cycles of chemotherapy plus immunotherapy with different checkpoints according to these trials, followed by surgery, and then getting immunotherapy afterwards. So just a quick word about pathologic response assessment. This is becoming more important because of it's being used as first from a trial perspective, it's being used as a primary endpoint for some of these trials is essentially a surrogate for, or a proxy for, the kind of longer term survival endpoint so that we can get these patients and these drugs or regimens into clinic faster. And essentially it's turning out to be potentially a predictive marker as well, as we'll talk about. But the definitions we commonly use are major pathologic response. So essentially I'm not a pathologist, but after several sections of the tumor, essentially the pathologist will estimate the percentage of viable tumor versus all of the rest of necrosis and all the other different types of cells. And major pathologic response is defined as less than 10% of residual viable tumor cells in the primary tumor and lymph nodes. Complete pathologic response is no evidence of viable tumor. And so, this system was actually, discussed in the chemotherapy era, where it was found that chemotherapy made, complete pathologic response rates were really uncommon, less than 5%. So this is the Checkmate 816 study. This is the neoadjuvant approach where patients get nivolumab plus chemotherapy for 3 cycles, and then they are followed with surgery and then whatever optional treatments by investigator choice. The primary endpoints here were PAT-CR and event-free survival. And you can see from these Kaplan-Meier curves for the event-free survival that there was a significant benefit with the hazards ratio of 0.63. Looking at the exploratory subgroup analysis, it was really the more advanced disease patients, the 3A patients that benefited the most. And you can see here PD-L1 status did matter, where they also benefited more. Looking at major the pathologic complete response rates, 24% in the nivolumab plus chemotherapy, and as we discussed for the chemo alone arm, it was less than 5%. This is immature survival data, but you are starting to see that separation. And so as far as adverse events, there was really no difference between the 2 arms. Adding the immune checkpoint inhibitor did not add. As far as what it did to kind of the surgical outcomes, and I'm sure Dr. Flores is going to bring this up, there was some delay or cancellation between both arms. But if you actually, the disease progression, the people that had disease progression, one could argue that's never changed. I mean, potentially those patients should not have been operable candidates. But it's really the adverse events, that should really be taken into factor. And it was quite negligible, very, very small. And the other reasons were patient refusal and so on for not going into to surgery, but it was generally well tolerated. So okay, and this is, I think, an important slide, because whenever we looked at that PAT-CR rate, whenever there was no CR, it didn't actually seem like the immunotherapy mattered. And so this is again exploratory in nature, but it's something to pay attention to. So just moving along very quickly for the sake of time, the perioperative regimens is highlighted by Keynote 671 that was just presented at ASCO and again demonstrated an improved event-free survival, and the overall survival is just immature at this point, but it's heading potentially in the right direction. As far as who benefits, pretty much everyone seems to be benefiting here, with the higher PD-L1 doing better. Back to this exploratory analysis for the PAT-CR, adding the adjuvant immunotherapy seems to have helped in this situation where they are seeing benefits for patients that did not achieve a PAT-CR
we have 1 minute left.
Yeah. So, okay, time. This is the adjuvant regimen here, where, patients essentially got surgery. This is kind of what we see in clinic sometimes whenever we get referred afterwards. And then the patients get immunotherapy for a year afterwards. Again, really improving disease-free survival. Really, the PD-L1 negatives don't seem to have benefit, but the expressors certainly do. It's hard. It's a hard ask for patients to be on immunotherapy for a year afterwards, and a lot of patients don't, unfortunately, make it through. So, for the sake of time, just to quickly summarize, early stage resectable cancer, it's our best opportunity for cure, but, unfortunately, a lot of patients are not cured. And these neoadjuvant and adjuvant chemoimmunotherapies with immunotherapies is showing promising results to improve the possibility of cure for these patients. Thank you.